It's your first meeting with Charlotte. So
Yes.
what was your intention and what did you discover? I don't know. Yeah.
Well, I guess I was just struck by how brave she is.
Mm-hmm.
How brave she is to be doing these interviews and how much pain, is still there. And, also how she's really questing to try to understand intellectually and emotionally, what's going on with her. The personality disorder is a shorthand for that. I thought it was interesting. She came to the interview with a preset transference.
Yeah.
Because she'd watched my videos, because she had been interviewed by Kernberg. She knew I was part of that group.
Mm-hmm.
So she was wondering,
Interesting.
well, what am I going to be? Am I going to be facing, the kind of situation I was facing when I was in the case conference?
Yeah.
And so that explains to me the level of anxiety I saw in the beginning of the interview, where she was speaking so softly I could barely hear her. And she just seemed quite, I think very anxious. And I was thinking, well, she's done this before. I wonder why she's so anxious with me. And then it became clear that she was anxious with me because she'd had some difficult experiences with people from our group in the past. And so she came to the interview almost with a preset transference, right? And that took a while to get through. But once we got through that, I thought she was incredibly forthcoming. And, I would have liked to, if we'd had more time, to go more into the issues about relationships. I think she's definitely somebody who's in recovery. She's in recovery.
Yeah.
She's made tremendous strides in her treatment. She has a direction, now professionally. She obviously is even doing individual counseling now, and she has a lot of concerns about that. That's not unusual. I've treated other people in the field who have become actually therapists, psychiatrists, psychologists, or social workers. So it's not unusual to go through that kind of period of questioning and doubt. But based on my own experience, the fact that one has had a personality disorder doesn't preclude having a career in mental health. And in many ways, one understands from the inside what certain things are like, and so that can be a real plus also. I think that, what I was talking to her about it towards the end is something that I am interested in. I don't have a developed theory about it, but I do think that there is a period where anybody who's had that level of self-destructiveness and self-hatred, has to really confront it and what they've done to themselves. And what I said about there being a mourning process, I think she's kind of in the middle. She's going through that.
When you said that, I thought, does Dr. Diamond mean a mourning process for mourning the loss of this being self-destructive? I mean, there's like different mourning, right? There's a mourning for if you've stopped the self-destructive behavior. That's one thing.
Yes, because
Gone.
That's a loss.
It's a huge loss.
It's a loss of the form of self-regulation. That's the kind of loss people usually talk about. But the mourning process I was talking with her about was just recognizing the gravity of the destructiveness towards the self. There's also a process of, like she was talking about, what she had done to this man and how she had hurt him too. And also the fear of something toxic. Well, that's turned on the self. And that's also something to be reckoned with. It's not just what they've done to others. The aggression is also what they've done to themselves. And so, and one has to then come to grips with that and also forgive oneself for that and make reparation. I mean, some people do it in different ways. Some people have plastic surgery, for example. Other people want to have the scars because it's part of them.
Right, but there's no one right or wrong. It's really it's your process of going through it.
I mean, I know a patient who actually lacerated her face. And she lived with that scar, and then decided that she wanted to have that removed because it was just a mark. It was like a mark of Cain on her face. And so she did. And that was part of her recovery. So there's no simple,
Right.
or one right way to do it, but I think it's facing the full force of that aggression is turned not just against others, but also against oneself, right? And that's to be mourned.
Right, and so it's a process, and you say that you think Charlotte's sort of in the, I mean, she's clearly in it. She's not.
Yes.
She's not doing it.
Yes.
She's facing the fire.
She's facing the fire.
Which
exactly.
is unbelievably amazing.
Yes.
And, I mean, to judge it, but
yes,
it's
yes, and facing
great.
what she did to her foot.
Yep.
And the aftermath of that.
Yep.
And then trying to learn to live with that. And
how do people do that, though? How do people forgive themselves when they do something that is going to never go away?
You know, if you think about it in terms of the model of forgiving oneself for aggressing against others and having caused tremendous damage, what does one do? You know, one has compassion for the person. One recognizes what one has done. One tries to make reparation. So I think being compassionate, kind to oneself, forgiving oneself, which is really hard. Some people can't.
Yeah.
You know, they continue to, if not physically, to psychologically lacerate themselves for what they've done. And being able to leave it behind, right?
But is that, you know, the act of sort of forgiving yourself or saying it is so actually abstract that sometimes to hear the exemplifying of that helps to concretize the notion of forgive oneself.
It's almost more understandable in the example I gave, where someone can do something concrete, can fix their body, you know. But again, not everybody really wants to do that.
Or could do
that. I mean, people deal with it in different ways. One way is to be open about it.
I see what you're saying.
To bear the scars and not try to hide it if it comes up, but to say that this is something I did in the past and I don't do it anymore. You know, it's the same thing with making suicide attempts. You know, to come to grips with that and not try to hide it, make it part of one's autobiographical narrative, so to speak.
Yeah.
You see, that kind of puts it in perspective. It takes it out of the realm of something that's not me, that's dissociated. But it's difficult.
Yeah.
Because the world views it in a certain way. So to integrate that in one's self-narrative, I think, is another way of having self-compassion. So that doesn't become a defining thing you have to split off from your narrative.
I see what you're saying.
Do you see what I'm saying?
Yeah.
The thing that came up in the interview, and I didn't want to go into too much about this, but it called to mind a patient I had who expressed just the most profound, she was an inpatient actually, the most profound self-loathing. And she thought she was hideously ugly. In fact, she believed she looked like a frog. In fact, she was quite a beautiful woman, young woman. And so, but that was almost a delusion. And there were people on the unit who thought she was psychotic.
Wow.
But I did not think she was psychotic. But I think there's a level of self-hatred that can be so profound that even clinicians turn away from it because it's hard to hear it. It's hard to endure it. And so they'd rather think of it as psychotic as opposed to this is something that can be part of the human experience, and it can feel just intolerable and terrible. And I think I saw her grappling with that, you know what I mean, trying to integrate what she's done to herself. I think the hardest thing for her to talk about was putting her foot through the window. You know, she was a little bit unclear about what happened, but when I said to her, "Oh, you mean you put your foot through the window?" She said, "Yes." I don't know if you noticed that. But
yeah, I didn't notice. That's interesting. Yeah.
But I think that coming to grips with that and really feeling how profound and painful, I mean, that is a level of pain that is almost unimaginable.
Yeah.
And I think that it's something that, as I said, I think clinicians have trouble hearing it.
Yeah.
And helping the person just to sit with it. Yeah. Right? But it has to be integrated, right? It's an extreme, just like imagining that one's, you know, omnipotent and can do everything. That's an extreme too. These things are all representations of the self that have to be integrated. And this is one of them that I think is among the most difficult to integrate.
Is there something like what I was always struck by when I learned about self-harm or eating disorder stuff was that these were behaviors that were also self-regulatory, and that they were attempts to not really hurt yourself, but to save yourself. That became very dangerous play. But, because of the feelings that were elicited in it that, were like a balm to the pain. And so what I wonder with an act like that, where you say self-loathing, is it self-loathing, or is that another attempt to self-regulate that then appears to be self-loathing?
Yeah, no, this is a very good point. And there's actually interesting research on this. But self-harm is self-regulatory, and it creates endorphins, and it's addictive. And that's why Linehan, started telling people to plunge their hands into ice water and do other things, just not cut themselves, because it would create the same level of self-stimulation. So yes, I think that's another way, and very viable way of looking at, self-punishment or self-harm. But I guess because I tend to think intrapsychically in terms of the internal world.
Yeah, that's why I'm asking.
You see, I'm very struck by something else she said, which is, I started to do this in response to having been abused by my mother. And I want to take it away from Charlotte. I want to take it pretty much every patient I've worked with who is, seriously self-harming. There's an identification with an internalized abusing person. So they take in the whole relationship, you see, and harming the self is also an identification with a powerful and punitive other that they can control, because now it's internal, and they're doing to themselves what that person did to them. And so it's regulatory in that sense too. You see, it comes out of an internalization of a whole relational scenario, and that has to be analyzed and worked with in treatment. And it's one of the good things I think about TFP is to work with that self-other dyad, to work with the dyad of the victim abuser, as it's in the room, as it comes up in vivo in the transference, you see. Yeah. This is our thought about one of the ways to work this through. Doesn't work for everybody. No treatment works for everybody.
No, of course.
But this is the model, you see. Yeah. And it's really important to identify that. Now, I also think self-harm it can be different for different people, but she's made a very clear point. This is something she did to herself because it was mimicking something that was done to her. Wow. And that's very common. I had a patient who began to cut herself after her father started abusing her and physically. And then she started getting into terrible accidents and winding up in the emergency room. She was doing to herself, as she put it, what he had done to her. And so it's not unusual for people to be able to identify that but not stop it.
There was one last question I had. I don't think it's an accident that Charlotte is doing this and that we've had a chance to work together for so long, because she's been driven to quest for this. And I'm just curious, with the people that you treat and just more generally, do you think that people need to have that in them to sort of overcome? It's what's saving her.
Look, it's a motivation to change.
Yeah.
And that's something we don't really understand. Okay. I mean, we all know people who have severe personality disorders who have no motivation to change. Yeah. And it's their kids who are suffering and like Charlotte, who are really motivated to change. But often, people can be quite disturbed and do very disturbed things to their kids. Yeah. And so I guess the answer is yes, they need the motivation to understand. Some people don't want to do that. Either it's too painful, they'd rather live their lives unaware and enacting things. So I think we have to come to grips with the fact that not everybody is treatable. I think that's a hard thing to come to grips with. But particularly if you're a clinician and you really believe in therapy, which I do, and its capacity to transform people's lives. But people walk away from it. Yeah. They say, it's too hard. I don't want this right now, or maybe ever. Yeah. As one of my patients who did that said, I want to stay in the attic. I don't want to come down. And what can you do?
Yeah.
You can't create that motivation. You just hope that person will come back. But anyway, I don't know if that answers the question.
And you know that really does. Thank you. Yeah. Thank you so much.